Okay, it's 11:15. We have our four speakers in the room. Welcome back. This is Men's Health Connected, and we're on day two. And today we're focusing on male health literacy and men's health promotion. Just had an excellent opening session with some great academics exploring the question, what is men's health literacy and why is it important? And I suppose one of the key factors that there was many, I should expect with academics, they didn't give us a simple three-word answer. It was a very complex and interesting conversation. But one of the answers was that we need to think about how do we use men's health literacy as a tool to actually find ways to help men engage more effectively with existing services, to design new services, and also to shift the dial on some of those health indicators we know impact men more than women, and impact men from certain backgrounds more than other populations of men. So in this session, we are focusing in then on a couple of those areas that we know really impact men's health. We've got a focus on stroke. We've got a focus on heart disease. And we're also looking at some work that's been done to test out a program engaging men at large farming events. So that's rural men, one of those communities, populations of men that do have worse outcomes than the average Aussie male. So, excuse me. We have Dr. Claire Seaman and Brent Smith, who are providing that talk on the initial findings of their research in that area. We have Natalie Rahul from the Heart Foundation. But starting the session today, I met her first when she was in the world of kidneys, and she's now moved to the world of stroke. It's all interconnected, and I'm sure there's lots of overlaps between the different body parts and different diseases. But today, Lisa Murphy is going to focus on sharing some very valuable information about stroke, how it relates to men, and how men are engaging in health checks around stroke. Lisa, thanks for being here. Over to you.
Thanks, Glenn. And before I start, Natalie and I did sort of touch base beforehand because there's quite a few crossovers, as you can imagine. So if you think I've missed something out and you're thinking, God, why didn't Lisa talk about that? It's because Natalie is, and we don't want to repeat ourselves. So I will just share my screen here. Okay, so have you all got that? Fantastic. Okay, so just before I start, I would just like to acknowledge the traditional owners of the land on which we are gathered here today. So for me, that's the Wurundjeri people of the Kulin Nation, and I'd like to pay my respects to their elders past, present, and emerging. And as I say that, I'd like to acknowledge that with all chronic conditions, the incidence of stroke and the impact of stroke for our First Nations people is worse than the non-Indigenous. And I've got a little bit to show you, hopefully later if I've got time, on what Stroke Foundation are doing in that space. So to kick off, I want to sort of share a few stories with you of some men who have had a stroke. The first one is Shane. So when he was 47, he had a stroke. He was a school principal, and he says, before my stroke, I need to move you guys out of the way there. I just didn't comprehend how important it was to keep my blood pressure under control. I was slack, and I was not proud of that. The reality is I probably could have prevented my stroke. If you're prescribed medication, don't muck around, take it, and make sure you eat healthy and exercise too. It could save your life. So Shane had his stroke while he was at school, and he collapsed in the staff room, and his colleagues tried to call an ambulance. He said, nah, I'll be all right, guys. I'm hard, I'm tough, I'll go home. And he went home, and it wasn't until 3 days later that he presented to the hospital with his stroke. He had to learn how to walk again, how to open a bottle again, all of these things. He got really badly depressed, couldn't connect to his family. He's now you'll be glad to hear, on a much better path. And he's actually one of our Stroke Foundation ambassadors. As you can see, he's got his nice t-shirt on there. This is Nathan. So Nathan had atrial fibrillation and high blood pressure without knowing it for about 3 years. And he had his stroke, and he describes it as his face melting, and he couldn't use his left arm. And when they did the scan, they found out that he had actually had 6 separate blood clots. So as you can imagine, when he's lifting his weights, his blood pressure is absolutely rocketing into the roof. When he got into the ambulance, it was 270 over 170, so really high. And he'd probably been on and off like that for the 3 years or more. And then finally, I couldn't get a photo of Leaf, so sorry, he's faceless man, but he's a father of 4, works at Telstra as a sales professional, and did then. And what he says, I was a typical male, thinking I didn't need to see a doctor. I knew my blood pressure wasn't very good. I took my medication when I remembered it, but I didn't make the changes that really counted: exercise and diet. So that kind of paints a picture of, you know, men's health in general. When we think about men not going to the doctors, not really taking an active role in their own lifestyle modifications. Obviously, you know, I'm generalizing, but these are 3 genuine case studies that we've got that we try and use to paint the picture of men's health and stroke. And the other thing that comes up over and over again is strokes don't happen to people, they happen to families. You can imagine the impact of a stroke on this young family. So this guy, Rodney, he's a farmer out in WA. They've had to give up the farm. They've had to move closer to Perth to get treatment. The boys have had to move school. So, you know, it's not just yourself, it's everybody, it's your community as well. Right. So I'm going to chat a bit about stroke in Australia, and then the big thing, obviously today with health literacy and health checks, is risk factors and prevention. Just a little bit on signs of stroke. Can't do a talk nowadays without mentioning COVID-19. A bit of cool tech stuff that we do at Stroke Foundation, a bit of fun stuff, and then I'm going to get everybody to make a little pledge at the end. Last year, we commissioned the Deloitte Access Economics to do an economic impact of stroke in Australia report. And what they found was in 2020, there were around 445,000 people living with stroke in Australia, and an estimated 27,000 people who were going to have a stroke for the first time. So that's not a recurrent stroke, that's their first stroke. And that means that about every 90 minutes, a stroke occurs. And then the other figure there is over nearly 9,000 people dying from stroke every year in Australia. What is alarming is, although in the more elderly population, the incidence of stroke is declining, it's actually getting higher in people of working age. So approximately 24% of new strokes in 2020 occurred in people under 54 years old, which is quite astounding. And this is on the increase. And I think this has got a lot to do with lifestyle factors, with blood pressure control, obesity, lack of exercise, all those things that can be prevented. And the other worrying trend is that 17% of people in regional Australia are more likely to suffer a stroke than in metropolitan areas, which is something that happens, you know, throughout chronic conditions. Heart disease, I'm sure, will be the same. And if we don't do anything, by 2050, the numbers are going to be escalating up and up, with 1,800,000 people in Australia living with stroke compared to today. So that's just staggering. But the good news is stroke can be prevented. In fact, 80% of strokes can be prevented. And this is really why we're here today, to talk about, you know, men's health literacy, actually doing something ourselves to prevent stroke. Because we're talking about men. The figures for men and stroke are a bit misleading, because even though the age-specific stroke incidence and mortality rates are higher in men than women, because women live longer and stroke tends to affect those that are older, the actual numbers of people with stroke, it's more common in women than in men. And the reason behind this is similar to heart disease as well. It's mostly related to sex steroid hormones, but there is some evidence that outside of the sex hormones, there are other factors that come into play, endothelial lining differences and things like that. So moving on to stroke risk factors and prevention, because school children around Australia are doing a NAPLAN test today, I thought we could do a little quiz. And I'm hoping you're going to get this right. And is it Mervyn, you're going to help me put up the poll, I think? So we've got a question. Here we go. What is the biggest risk factor for stroke? Is it male gender, family history, high blood pressure, or atrial fibrillation? I'll give you a couple more seconds to answer.
Yeah, we'll just give it a little second for the attendees to answer. About 42% have voted so far, but just let me know.
I'll give you a few more seconds. Okay, we've got 50%. Oh, there's a flood of votes at the end. Okay, so the correct answer is high blood pressure. And high blood pressure is by far and away the commonest cause of stroke, which is good news and bad news. The good news is it's something we can absolutely do something about. The bad news is we're not getting very far. Okay, we can stop that. Next slide. Is the poll up, which is why it's not moving to the next slide, maybe? Oh, there we go. So these are the sort of risk factors for stroke. There's things you cannot do anything about, like being male and your age, but there's things you can absolutely do things about. So the other risk factors are smoking, alcohol, obesity and overweight, exercise and diet. So nothing groundbreakingly different from any other chronic disease, really. There are medical risks that increase your risk of stroke. So if you've had a stroke before, if you've had a heart attack, or if you've had a transient ischemic attack, or some people still call them mini strokes. If you've got a family history of stroke, not much you can do about that. And if you've been diagnosed with high blood pressure, high cholesterol, type 2 diabetes, or atrial fibrillation, that's often something which you can't do anything about, but you can manage it. So managing it well with medications or with diet and exercise. And that's just a summary of that. But as I said earlier, the good news is that more than 80% of strokes can't be prevented. Obviously, there's some that can't be prevented. So ruptured aneurysm sometimes, genetic causes of stroke, but a lot of the time it can be prevented. So we spend a lot of our time at Stroke Foundation looking into activities to highlight blood pressure. And one of the things that we do is the Australia's biggest blood pressure check. And it's all around getting out there and getting people's blood pressure checked. In 2019, we did a lot of blood pressure checks in pharmacies. Went to 400 locations, and actually what we found was 13.8% of people measured had a high blood pressure. And look, males were a lot higher, 16.1 compared to females. This during COVID, we obviously weren't able to do those checks, but this year we're partnered with Bloom's the chemist, and we're doing blood pressure checks actually for the month of May. And we also have a little van, which you can see there, where we drive around just in Victoria and do blood pressure checks. We just recognise that blood pressure is so important for stroke. We also up in Queensland partner with Heart Foundation and other alliance partners to deliver the My Health for Life program, which is all around primary prevention of chronic conditions. And it's a real behavioral change approach where you choose your own goals and you work towards your own goals with support of the My Health for Life staff. And you can see the successes there in terms of reducing waist circumference, increasing physical activity, and improving diet. It's something we'd love to roll out nationally, but obviously funding is always a challenge. The other piece of work we're doing with the Heart Foundation and the other members of the Australian Chronic Disease Prevention Alliance, so that's Diabetes Australia and Kidney Health Australia, is we're updating the absolute cardiovascular risk guidelines. So these are really quite dated now, 2012. And as part of some funding that was associated with the National Strategic Action Plan for Heart and Stroke, we got some funding to get these updated. So Natalie and I are quite involved in this project. And we're kind of 8 months in, and there's a lot of groups that are advising us, very, very, very clever researchers and physicians in the cardiovascular disease space. We've got probably another year and a half, even probably a bit more to go, but it'll be very exciting to actually see those guidelines updated, because that'll play a big part in assessing people's cardiovascular disease risk. I've got another little quiz for you here. It would be amiss of me not to talk about the signs of stroke in any presentation that we do as part of Stroke Foundation. So if you could answer the questions there. It's a bit tricky, this one. Oh, I've just realized it's come out as, it was meant to be a multiple, you can choose multiple options, because obviously there's more than one signs of stroke. So I might, but people are generally getting the right, interesting actually. No, I'll stop the poll there, but so speech difficulties, paralysis, facial drooping, but palpitations cause a stroke but not the sign of stroke, so AF, heavy sweating and jaw pain, not so much. So that's an interesting result. I will go through that with you now. So if you could stop the poll there. Okay, another one, and I'll go through the signs in a minute. So if you thought somebody was having a stroke, would you A, visit their GP as a matter of urgency, go lie down and rest, call 000, or get them to have an appointment with their GP? Okay, we'll probably end that there. So the majority of you said call 000, which is fantastic. One was visit their GP as a matter of urgency. So stroke is always a medical emergency, always call 000. Time is brain in stroke. Every minute that you have a loss of blood supply to your brain, you lose 3 million brain cells. So if you think the minutes add up, there's a lot of brain cells. Okay, that nap plan is now over, guys. You'll be relieved. So these are the fast signs of stroke. So there are other signs, obviously, but these are the main ones that happen most commonly. And also, you don't want to over bombard people with information because they hardly remember these ones at all. So face, has their face dropped? Arms, can they lift both arms? S, is their speech slurred, just like mine is there. And T is time. So call an ambulance. Don't go to GP, just call an ambulance. And what we do find is when we do surveys of people being aware of the signs of stroke and calling an ambulance, it's actually pretty poor. So that top one is unprompted, so you don't sort of give them any hints, really, 16%. And then when they're prompted, remembering 3 signs, it's 46%. So we've got a lot of work to do. And unsurprisingly, it's worse in English speaking households and culturally and linguistically diverse households.
In Australia, stroke occurs every 19 minutes. When stroke attacks your brain, up to 1.9 million brain cells die every minute. Think fast. F, face. Has their face drooped? A, arms. Can they lift both arms? S, speech. Is their speech slurred or confused? T, time. Call 000. Time is critical. Stroke is always a medical emergency. Act fast. Call 000.
We've actually done some of these messaging in different languages, and we had a partnership with SBS to put them out on their station, so that was fantastic. A very quick bit about COVID-19. It had big direct health impacts, but also indirect health impacts. Calls to 000 were down. Stroke units got reallocated as COVID wards, rehab services closed. But on the positive side, telehealth was completely turbocharged, and that included rehab as well. The Stroke Foundation National Stroke Guidelines we used that model to then get COVID living guidelines. We started a national webinar series as well. So there is a silver lining amongst all the terrible goings on of last year and this year. And I thought this was really interesting. And we all know that, the referrals and diagnosis of cancer were down, as you can see in this one. But also, amazingly, numbers of CT scans dropped. So that's January 2020. And the number of retrieval of clots dropped. And that's only going to have a knock-on effect. I will just talk very quickly about some cool tech stuff that we do. So we have now got CT scanners in ambulances. So if you have your stroke and a mobile stroke unit comes to you, you can get diagnosed as a stroke in the ambulance and receive your clot busting treatment in the ambulance. It's amazing. If you talk to people that have had this, they say they can feel their arm coming back, the feeling in it before they've even got to hospital, which is absolutely incredible. If you think about somebody out in rural Australia who has a stroke compared to somebody that can get in one of these ambulances, that's just incredible. And what we are doing now is trying to get little lightweight CT scanners into airplanes so that they can fly out to rural and remote Australia and actually scan people in the airplanes, which is incredible. So that's a new project that's just launched now through the Australian Stroke Alliance. The other cool thing is telehealth, and this links into the ambulances as well. So having link ups with clinicians in metropolitan areas to emergency departments or GPs in rural areas. And then the cool thing that we do is the Living Stroke Guidelines. I might just skip over those because I want to get to your pledges. Oh, got to talk about the fun stuff. So this week it's the towel challenge, where you can join in, wrap a towel around, please cover the important bits, and raise funds for stroke. And also a little shout out for Stroke Week, which is coming up in August. Okay, my pledges for you. So I've got 3 things that I need you all to do. Get a health check and tell a mate to get a health check. Not only do that, it's all well and good knowing you've got a high blood pressure, but do something about it. make a pledge to keep on your medication, get some exercise, lose some weight, eat healthily. And then my final pledge for you is to recognize the signs of stroke and tell your friends about it. Thank you.
Right. Thank you, Lisa. You've covered a huge amount of territory in such a short period of time. So that's Dr. Lisa Murphy, who's the Executive Director of Stroke Services at the Stroke Foundation. I think we've got a couple of minutes for a couple of questions. I've already picked one up in the chat box. I've got a couple myself. But also right now, if you've got questions for Natalie with a particular focus on stroke and men, anything that came up in the presentation or anything that wasn't covered in the presentation, either raise your hands using the icons in your toolbar, or just drop your comments in the chat box there as well. So a couple of quick checks on the, apologies about if I missed it, but you were talking about the big Australian blood pressure check, but also the work in Queensland.
Yes.
I think you had like over 400,000 people participating in the blood pressure check, and you had a measure of how many men who took the check had blood pressure, but also interested to know what was the engagement in terms of men and women in that 400,000.
So pretty good, actually. You would think that men wouldn't roll up to, participate, but, often men go shopping with their wives. So the ones where we had the results were in Priceline pharmacists. And so the partners or the wives would cajole their partners to go, get their blood pressure checked. So actually it was a fairly even mix.
So in the region of 50-50.
Yeah, which is
right.
Surprising, I thought.
And does that include those sort of the robo blood pressure machines where you can just walk up without human interaction, the gaming approach?
So you stick your arm in the cuff and stand on the weighing scales, and you get measured and weighed and your blood pressure done. Yeah,
well, I don't want to assume gender stereotypes, but let's say men love machines, and maybe robo blood pressure checking is in fact a form of male friendly health check, but something maybe to explore further.
They don't have to talk to anybody.
That's right, except for the machine, yeah. And following on from that, you mentioned that there was an initiative going on throughout May this year. Could you just remind us what that is? Is there any link we could post to it? And Neil Davis in particular asked where can we find out about where those checks are taking place?
So this year it's a bit low key because we're all getting going after COVID, but it's a partnership with Bloom's Chemist, and they're mostly, there's not many of them in Victoria, but they're mostly in New South Wales, but also nationally. So they're running blood pressure checks for the month of May. You can hop on the Stroke Foundation website and all the information is there. Other than that, a lot of pharmacies do blood pressure checks, and your GP absolutely does blood pressure checks. So pop into your pharmacy. The other thing to say is, it's amazing how much your blood pressure fluctuates over a 24-hour period. So if you are concerned, buying a validated blood pressure device from a reputable pharmacy and just measuring it at different times of day, it's quite revealing how much your blood pressure changes.
Great, thank you. Great question in the chat box, leaning more into some of the social determinants of health. In short, talking about the link between blood pressure and stress, and the lives that people live in terms of work pressure, family pressure, maybe not doing what the heart loves, but doing what they have to do. Mm-hmm. So, are there ways of measuring that? Do you have a way of sort of looking into that aspect of blood pressure?
I think it ties into what I've just said before. Don't just take your blood pressure when you visit your GP and maybe you're feeling more anxious or less anxious. Take it when you've just had a crazy day at work and the kids arrive from home, just to see what it is like. The case study I showed you with the fellow who was weightlifting, he had no comprehension about how much his blood pressure would go up, and that sudden surge was probably what gave him the stroke. So be mindful. And sort of to be a bit more holistic there are ways of practicing mindfulness and meditation. It doesn't have to be, the sort of, you don't have like incense and stuff. There are many ways to practice mindfulness, and that is a great way to bring those stress levels down. It's
Great.
not just for girls.
You heard it here first, folks. Incense, sticks, and meditation is not just for girls. In fact, can I just say that on Wednesday, tomorrow, and I'll post a link, we have our Men's Health Champions event, which includes many of the great groups working with men around the country, including a group called Meditation for Men. So go check out that program and get yourself online tomorrow if you want to join us for that session. Thank you, Lisa. That was Dr. Lisa Murphy, who is Executive Director of Stroke Services at the Stroke Foundation. And now picking up some of the gaps that Lisa skillfully left for her colleague to fill, as well as extending into heart risk. We have Natalie Raphael, who is the National Risk Reduction Manager at the Heart Foundation. Over to you, Natalie.
Thank you, Glenn, and thanks for that introduction. And what a fantastic presentation for me to follow. I can't promise to fill the same shoes that Lisa did, but I'll try my best. I think there's, while I'm uploading my slides now, or just bringing them up, there is really, truly so much to cover in this space. And I think Lisa's provided such a great breadth of exposure across what the Stroke Foundation is doing. Today, I think my presentation will focus a little bit more on upskilling you all on the risk factors for heart disease. I will attempt to dive into some that are specific to men, or the differences that we see in risk and in the male population, but also unpick some of the formative research that the Heart Foundation has done to look at what drives people to go in and get a preventative health check, and where things may differ for men and women. So apologies in advance, it will be a whirlwind tour, and I won't even have covered a quarter of what this space looks like at the moment, but I'm very grateful for the invitation, and we'll see how much we can cover. By way of background, I'm a clinical cardiology pharmacist previously, and I'm currently the risk reduction manager. And the way I guess that sits, and for your awareness, is that the Heart Foundation has a new strategy. It's a 3-year strategy called the Connecting Hearts strategy, and it focuses on 3 strategic pillars, one of which is risk reduction. So we're aiming to support more Australians to take action to manage their heart health before they develop heart disease. So it's all about prevention and health checks. And our other arm aims to support people living with heart disease and reduce their burden and improve their quality of life. And the 3rd strategic pillar is all about funding life-saving cardiovascular research, which the Heart Foundation does very well. So today I'll be talking about risk reduction related activity, and I'll kick off by reminding you all, I'm sure you've seen this before, if not heard it very, very recently, in that, ischemic heart disease, encompassing mainly heart attack and unstable chest pain, was the top ranked leading cause of death in Australia in 2019, and it really continues to be for some time, as you can see. Although mortality rates have dropped increasingly over time, we're seeing more and more Australians living with risk factors for chronic disease, so more and more risk factors for chronic disease, including things like high blood pressure and high cholesterol, but also diabetes and obesity. In terms of specifically looking at males, we can see almost twice the number of deaths compared to, the second ranked cause of death, in this case dementia, including Alzheimer's. So it is absolutely top of mind for men in Australia. It continues to be, our number 1 killer, and I don't want to kill you with stats, because there's quite a few in this presentation, but it's suffice to say that it has an incredibly high burden on the Australian population, not only from a health perspective, but also from a financial perspective, from a health system point of view, all round. One point I did want to make up front at this presentation is that we know that 83% of the burden of cardiovascular disease is actually premature deaths. People aren't living years and years and years with it, but they're dying earlier than they should. And that is one of the, the most important arguments for why why we need to prioritize preventing heart disease before it develops. And throughout this presentation, I think I'll hopefully cover a few more really strong arguments for why prevention is absolutely critical when it comes to heart disease. It's the only way we will rid Australia of this horrible condition. I think, you know, the Heart Foundation also recently published a report showcasing just how many lives and heart attacks and strokes we could prevent if we treated high-risk individuals with the appropriate medications according to guidelines. Whilst this is not the focus of my presentation, because I could genuinely talk for 40 minutes about the gaps in practice, the under-prescribing of life-saving medications in high-risk Australians. It could be maybe another talk for another day. It is absolutely an issue in the Australian population, and in particular in primary care or in general practice. When it comes to high-risk Australians, there are millions, quite literally 2.5 million Australians at high risk of having a heart attack or stroke in the next 5 years. And astonishingly, over half of these Australians have never had an event before. And so it's safe to assume that many of these people will not have heart disease front of mind or stroke front of mind. Specifically, as it relates to men, we know, of this 1.5 million men are at high risk of having a heart attack or stroke in the next 5 years. So it is a really big issue for Australian men. When we look at the stats or the burden at a gender breakdown, or just looking at men, we know that in 2019 over 10,000 men died from heart disease. It takes the life, unfortunately, of 29 Australian men each day. And we know that there are hundreds of thousands admitted to hospital for heart disease over a year. And we know, more than 300,000 are living with heart disease each day. And that's likely to be an underestimate because of the way it's recorded. So it's a huge issue for men. And, it would be good to talk about correlating how big of an issue this is for men, and how possibly they do or do not value preventative health checks in a minute. In terms of sex differences, I think, Lisa, you've done an awesome job at covering this already. I just wanted to highlight that when it comes to cardiovascular disease or risk of developing cardiovascular disease, and men tend to develop cardiovascular disease at a younger age, as Lisa mentioned, and so their risk is higher earlier on compared to women. And then in contrast, and Lisa's covered this as well, that women tend to be at high risk of stroke, but often, again, that's related to their longer life expectancy. Overall, in women, CVD tends to develop 7 to 10 years later. I'd probably bring that down to about 5 to 10 years, but later in women than it does in men. And it's still a major cause of death in women. There's almost a delayed protective effect from often it's linked to estrogen, but there are a few other causes that we could see having at play at the background to this effect. Overall, if we look at men and women, their lifetime risk of cardiovascular disease is quite similar. It just happens at a different time. And I know, often it's just one thing that we think about, okay, after menopause, women are at high risk, and before that they're protected. But there are quite a different range of risk factors that have a differing burden on men and women, or impact men and women differently, sorry. And in terms of men, what we see is that age has a higher burden on their risk of developing heart disease. Hypertension or high blood pressure has a higher burden. Total cholesterol often is more prevalent, has a higher burden. And in particular, looking at different types of cholesterol, LDL cholesterol, or the bad cholesterol, has a greater impact on the risk of men developing heart disease. Whereas in women, the risk profile we see, or the risk factors that have a greater burden in women, it tends to be smoking, diabetes, high triglycerides, which is often accompanies diabetes, and having low good cholesterol, known as high density lipoprotein or high HDL cholesterol. So there are differences in risk factors as well at bay. And in women specifically, we know that they have a number of female-specific risk factors that elevate their risk of developing heart disease, including things like gestational diabetes or hypertension or high blood pressure during pregnancy. So that's a bit of a breakdown on gender differences. But what I really want to reinforce, particularly about the preventative aspect of this all, is that, you know, the buildup of plaque or fatty deposits in the coronary arteries, or the arteries that supply oxygenated blood to the heart, that starts from early on. In fact, it actually starts in adolescence. So we're all starting to build up a bit of plaque in our arteries from our, you know, teenage years, really, and it's from that fourth decade of life where this starts to become an increasing issue. And that's why our preventative health checks start from often 45. And in the case of a heart health check, 45 is the recommended starting point for assessment, because it's at that point where, you know, things start to build up, and when you add in more risk factors, that risk gets higher and higher. Often people tell me, oh, well, look, I only smoke, but I drink really well, I exercise really well, so I only have one risk factor, and there are many others, so, you know, I should be okay. But unfortunately, it's not just about the number of risk factors you have, it's about how they combine to increase your risk of having a heart attack or stroke. And it's not a simple linear combination. It's not, okay, if I have 1 + 1, it's 2 risk factors, I'm at twice the risk of developing heart disease or stroke. It's more complex than that, but it's suffice to say that there are quite a range of risk factors, some that we can't change or do much about. And, you know, our age is a classic example of that. As you get older, your risk increases. Ethnicity is, again, something we can't change, but it has been shown that people of Aboriginal and Torres Strait Islander descent absolutely have a higher risk of developing heart disease. In fact, they develop it earlier and in a more severe state than non-Indigenous Australians. And people from the Indian subcontinent, or even those from a Maori or Middle Eastern descent, often have a higher risk of developing a heart attack or stroke. Gender, you know, I've put it here because it is absolutely another risk factor. Men are at high risk, particularly relative to the women of the same age, but we know women have female-specific risk factors as well. Family history is another one. This one's a tricky one, because I'm sure everyone knows a family member that's had heart disease. Having a family history of premature heart disease, so heart disease that develops in a close relative younger than the age of 55, is known to increase your own risk of developing heart disease significantly. And this is, again, something we can't change. There are many things we can change, and known as modifiable risk factors. And I think, you know, Lisa's covered some of these really well already. Smoking and the connection between smoking and heart disease and stroke is really solid. And bad cholesterol, or LDL cholesterol on my previous slides, this tends to stick to the walls of your arteries and causes blockages. And so high cholesterol and high blood pressure are two of the leading causes. So blood pressure is the leading cause of stroke, and high cholesterol is the leading cause of heart attacks. So together they create two of the biggest issues in the country when it comes to heart and stroke. Diabetes is often overlooked, but having diabetes can almost double your risk of developing heart disease. People with diabetes are known as the kind of really super high risk individuals that can go on and develop more and more heart problems. And being physically active and eating unhealthy, you know, I think we're all really aware of these risk factors for heart disease. So before I go on and tell you about how men are engaging with heart health checks, I thought I would explain what a heart health check is. A heart health check is really just a simple preventative checkup that an individual has with their general practitioner or with their GP. During that time, your GP, possibly assisted by their practice nurse, will check your cholesterol, your medical history, your blood pressure, your lifestyle. They'll get your blood sugar levels, and they'll check your family history and really take a full comprehensive clinical assessment of your risk. They'll use validated risk calculators or clinical calculators to estimate your chances of developing a heart attack or stroke in the next 5 years. And this is really important because what the evidence tells us is that GPs and many health professionals, not just GPs, are not very good at calculating clinical risk in their head. It's a hard thing to compute. No human really is very good at it. And so having a validated calculator that guides their therapy and their decision-making in this space is really important. And the third step of the heart health check is the most important one. It's where the GP sits down, and possibly even the practice nurse sits down with you and sets a plan to help you reduce your risk of developing heart disease. And that may include things like supporting you with healthy lifestyle advice, or actually referring you on to get more support, like, you know, the My Health for Life program in Queensland. It might involve, if you're at high risk, it might involve starting new medication, and it might involve, you know, being referred on to dietitians or other specialists that may be required. So it's really that starting, the first preventative starting checkup with your GP. And there are many things that people can do to lower their risk. I won't go through all of them, but this is just a kind of 10-step guide that covers probably 10 of the most important things that we can do to lower our risk of developing heart disease. And they include lifestyle factors, as well as clinical things like managing blood pressure, cholesterol, and diabetes well. You'll notice we have added, you know, managing mental health, because it is such an important risk factor, as well as byproduct, unfortunately, of heart disease, which influences people's risk of developing heart disease. So now that we know what heart health checks are, and the issue with people at high risk of developing heart disease, we probably want to cover a little bit about what drives heart health checks. And the Heart Foundation was very interested in this very question probably 2 years ago now. And we commissioned a piece of formative research that involved consumer focus groups, online forums, and in-depth tele interviews, as well as searching the literature and you know, finding out what we knew was already published. And what we really wanted to know was what encourages individuals, especially Australians, to visit their GP for a preventative check, and what really is the barrier right now. Because if everybody saw their GP for a heart health check, then we would have a lot less heart disease prevalent in the country. So obviously that's not happening. The research showed us a few things. One is that these are the people, this is the kind of profile of the person that's more likely to come in for a cardiovascular related health check. So older people, and that makes sense, they've got other chronic conditions, they're showing up anyway. Women, particularly compared to their male counterparts, were more likely to attend for a preventative checkup. And people that are married or people with families were more likely than singles to present for a checkup. And no surprise, you know, people living in affluent areas were more likely to show up. Sorry. And conversely, the people that are not showing up, the people that, you know, we really need to encourage to come in for a check, were smokers. That's well documented in the literature. Part of the possible explanation to that is wanting to avoid having to talk about quitting or not being ready for quitting. Men are not showing up compared to women. And in fact, I went back and rehashed some of this research to really confirm my thinking, and that there were men, particularly in the focus groups, aged younger than 50, who really openly expressed their reluctance to see their GP for something that wasn't a current issue. They said, you know, they would see their GP if something was wrong with them, if they were unwell. I would even question that, you know, that to the extent of how unwell they were to see their GP. But they said it's very unlikely that they would consider seeing their GP as a preventative measure. And this is a key issue. So, you know, forums like this and others really would be a great place to brainstorm how we can address this in the future. People from low SES backgrounds were less likely to see, and that might have something to do with access issues, but also people with more risk factors for developing heart disease. And this is the heartbreaking one, because these are the high risk individuals. These are the people that can gain the most out of the preventative check. They're hardest to bring in. So yeah, people from different ethnic backgrounds were also less likely to attend. And you can see the picture of this profile is also reflective of some of the inequity issues in Australia more broadly across other health conditions. So after this research, and as I said, you know, bringing all these pieces of research together, we identified a few areas of enablers and barriers when it comes to heart health checks. You know, one of the key barriers or enablers in the other way is that people need to feel that cardiovascular disease, whether it's a heart disease or whether it's stroke, they need to feel that it's relevant to them. If you tell them a stat about how important it is or how many people die every day, that's not personally relevant. You're not connecting it to them, and so they're less likely to actually act on it. People that don't understand the preventative nature of cardiovascular disease are also less likely to attend. And we certainly saw a knowledge gap, and this was in the early days, so 2 years ago. Heart health checks were probably not as well recognised as they are now. And if people don't know what's involved in the checkup, they just won't come. So for instance, when we asked some of our focus groups, what do you think is involved in a heart health check? They said, do I have to get on a treadmill? Do I have to do an echo? Is it like an angiogram where they put a camera in my artery? And none of those things happen during a heart health check. It's not invasive at all, but it just goes to show that when you don't feel that knowledge gap, people feel it with their own opinions or assumptions. Social support was really important, and having social networks, particularly women influencing their family and their partners in that network, was really important. And I think that's something we can absolutely leverage when it comes to promoting preventative checks with men. And access is, again, across many other chronic conditions. The last one I've highlighted because actually it was one of the strongest motivators that we identified, and that was that people were admittedly a lot more likely to see their GP for a heart health check if they received a personal invitation from their health professional. And the Heart Foundation, although again it won't feature in this presentation, the Heart Foundation is currently running a national recall pilot with over 200 general practices across the country that does just this. Personally invites or recalls individuals that need to have a heart health check into the practice to deliver these checks over the next few months. So we're addressing some of these already. I will touch on this very briefly because I don't want to get too far into the Medicare stuff. It's not that exciting, but in April 2019, the government announced a new Medicare item that was introduced in general practices. So general practice works, as many of you will be aware, in a fee-for-service model. And one of the new checks or services that would be subsidised by Medicare was a heart health check. And it was the first item to be introduced that's ensured that GPs actually calculated somebody's cardiovascular risk during the checkup, and it was able to be claimed every 12 months. So it was a regular check that could be provided by the GP, and it was specific to heart disease. It gave general practices an excuse really to focus a little bit more on preventing heart disease rather than just waiting for people to kind of developing a condition before treating them. And since it's been introduced, there's been over 180,000 heart health checks delivered in Australia, and you can see it was introduced in April, and that's the most recent data we have. But specifically, if you look at the gender breakdown, we're doing really well overall nationally with a fairly 50-50 split between men and women. And this is really encouraging because it shows that these services are being delivered almost perfectly evenly across men and women in Australia. We had expected the male population to be a lot less likely to take it up, but this is very encouraging. When you look at it state by state, I won't run through them all, but possibly in Tasmania, we've got less men showing up, and so that could be the telling signs of a small initiative that we could run in Tasmania to address some gaps there specifically for men. And sorry, I'm sure I'm over time, so I will whiz through this last thing, but I had mentioned that ensuring people personally understand the relevance of cardiovascular disease to them and their families is really important. And one of the ways the Heart Foundation has done this is by launching a heart age calculator. So heart age calculators are internationally recognized. Pretty much every country overseas has one, and new prevention guidelines for heart disease are incorporating them as part of their recommendations, particularly for communicating risk to individuals. So if I tell you you're at high risk of developing heart disease, you say, okay. And I say, oh, well, that means you have a 25% risk of developing heart disease. And you tell me, well, 75% chance I'm not going to get it. That sounds okay, sounds sweet. I'm not really high risk. And you may not do anything about it. And so the issue of communicating risk has been around for decades, really, and there have been lots of different ways that researchers have tried to address tries to address this gap. And one of the, I guess, key strategies has been to introduce a way of people having to calculate their own risk of developing heart disease and finding out how that compares to a healthy man or woman their age in Australia. And that's what Heart Age does. It collects your information about your risk factors. So it asks you if you have high blood pressure. If you don't know, it uses the average in Australia for your age and gender. It asks you whether you smoke, whether you have diabetes, whether you have a family history, and it incorporates all these risk factors to calculate a age. And essentially, if you have one or more risk factors for developing heart disease, you have a higher heart age than your actual age. And since it was introduced, we've had over 1.8 million Australians calculate their heart age. And it's been recently published actually by the Heart Foundation, shown to impact the behavior of individuals after they get their heart age calculated. So people are more likely to recall what their risk was. They're more likely to have an emotional impact, because if you tell a woman she's older than her actual age, she might get insulted. And certainly there were many men that were insulted as well, or felt like it was something to stop and think about. And it also was shown to increase positive lifestyle change and increased clinical checks with GPs and even calculation of blood pressure and cholesterol. So we're onto something here. The disappointing part is that men, unfortunately, were a lot less likely to calculate their heart age. So they're less likely to engage with this digital format. You can see 60% of that 1.8 million completions were women versus less men. And so now the Heart Foundation, and they're not the only ones. There are other people, smokers are less likely to engage, other groups are less likely to engage. And so now we're thinking about, okay, so how do we reach these high risk people or hard to reach people with different forms of engagement? So I won't do it now because I think we've run out of time, but if you have a break later on in the day, I would love for you, and I'll put the link in the chat, love for you to calculate your heart age. Tell me what you think. It's for anyone 35 to 74 who hasn't already had heart disease. Heaps more information on the Heart Foundation's website, including a host of Indigenous specific resources encouraging Indigenous Australians to get a health check. Thank you, and I apologise if I was running over time.
Natalie, that was fantastic. You've squeezed an extra couple of minutes out of the programme, but that's okay. We could have, I knew when I first spoke to you, we could have given you a whole day and you still would have been interesting and engaging. Unfortunately, we just had that 20-minute slot. Thanks we've learned a lot. I hope we get an opportunity in future to delve down sort of deeper into some of that, and particularly exploring some of the ways we can break down those barriers to engagement, not just with men in general, because it seems that on one level, in terms of the heart health checks, we're certainly reaching a good number of men with a couple of localized expectations. Interesting that men so far aren't as interested to know their heart age, but also important for us to remember just how much earlier heart disease is hitting men in Australia. I think last time I looked, when you look at deaths under 65, men are 4 times more likely to die of heart disease under 65. So there's some work to be done there in terms of getting to men earlier with our preventative work, and rising, but also interested to have it confirmed that those least likely to engage are those most at risk, which is perhaps the most heartbreaking part of the information you've shared. And so more thought clearly needs to go into how do we actually engage those who are absolutely most at risk and could most benefit from changes that could extend and save their lives. So thanks for your talk. I'm just wrapping up because there isn't time for questions, but please have a look in the chat box. I'm sure people have been commenting or might have questions. We're going to go to our final talk. So a shorter talk to finish off with, but no less meaningful and important. We have Dr. Claire Seaman and Brent Smith. I think, I'm not entirely sure, but I think it was Professor James Smith pointing me towards lots of different research that's going on at the moment that that highlighted me to their work. They've been evaluating a health program that targets a large audience of men in rural communities at a large agricultural show. So this is an example of what happens when we reach out to some of those harder to reach and more at-risk communities like rural men with specific programs. I'll hand over to them. I'm struggling to do a good summation of their research. Why am I doing that when I have the experts in the room? I'll hand over to Dr. Claire Seaman and Brent Smith, and we'll go a little bit into the lunch break to make sure you get your full time if needed, guys. Over to you.
No worries. Thanks, Glenn. Look, I'll start off and just really set the scene of the actual health program, health screening, health promotion, and then Claire will finish up with some of the stats side of things and our actual evaluation, our research from the event. So it's a slide.
Brent, can I just check that I'm sharing the right screen when I do? Is that
yes, perfect, Claire.
Perfect.
That's
cool.
Perfect.
Thanks.
So no worries. So look, it's a slight change of tack to what Lisa and Natalie were chatting about. It's more around health screening, health prevention, health promotion, and actually trying to pick up some of these issues before they start. So before I start, we would like to start with an acknowledgement of country. So both Claire and I are based on Wiradjuri land, and we would like to acknowledge the Wiradjuri people as the traditional owners and custodians of the lands in which we are meeting from today, and pay our respects to elders past, present and emerging. And we should also acknowledge our funding. So Three Rivers University Department of Rural Health is funded by the Australian Government through the Rural Health Multidisciplinary Training Program. So as I've said previously, we'll be chatting about an evaluation of a specific health program or initiative called the Spanner in the Works program, which is led primarily by the Australian Meds Shed Association. I've worked with these guys for a couple of years now. We've delivered multiple iterations of this program. This one specifically that we'll be chatting about is our 2019 program. Naturally, COVID hit last year and we didn't run the event. However, we are planning on rolling out bigger and better this year for 2021, fingers crossed. But the Henty Field Days is a large agricultural event held in Henty, which is near the regional centres in New South Wales of Albury, Wodonga and Wagga. Runs over 3 days. There's approximately 800 exhibitors and 60,000 people through the gate over the 3 days. So as I said, I'll start off, set the scene, how the program works, etc. Claire will discuss the evaluation and research side of things. And based on the study, which Glenn has alluded to, that we published with our colleague Elise Green last year in the Health Promotion Journal of Australia. So as we know, men from rural and remote areas have been identified as a priority group within the Australian Commonwealth Government's National Men's Health Strategy 2020 to 2023, with chronic health conditions, diabetes, injuries, prostate cancer, mental health being identified as high risk outcomes facing this subpopulation. There are many reasons in particular men fail to access health services, and taking health initiatives to men through events such as the Henty Field Days is seen as an ideal way of reaching at-risk men with basic health assessments and general health promotion strategies due to their attendances at such events. So the Spanner in the Works program is a men's health initiative initially developed by the Australian Men's Shed Association and Healthy Male. Operationally, the Australian Men's Shed Association conducts these health checks and health promotion events as per the Spanner in the Works program in men's sheds and larger events such as field days across Australia. The Australian Men's Shed Association staff, Stuart Torrance, who is the Men's Health Project Officer, and Marty Least, who is the Event and Volunteer Coordinator, are pivotal to its rollout and success. And you can see them in the picture there in the blue shirts with the students involved in the program. So both Stuart and Marty have been fantastic to work with, and we look forward to this collaboration continuing into the future. So how the program works and basically what we've delivered, particularly for our 2019 offering and our research project, is basically we conducted over 400 health assessments run by students in 2019. So this ran with approximately between 8 and 10 students each day, overseen by supervision by qualified health professionals. And for the health assessments, we screened particularly for low risk activities and as well as low risk infection control activities such as blood pressure. And the blood pressure was determined by the Australian Heart Foundation definition of greater than 140 over 90 millimetres of mercury. Waist circumference, and this was determined by the Australian Government Healthy Weight Guide of more than 101 equals greater increased risk of developing chronic disease such as type 2 diabetes mellitus and health disease. We also screened for diabetes risk as per the AUSD risk classification, which is a validated assessment tool of predicting the 5-year risk of developing type 2 diabetes based on 9 demographic, lifestyle, and simple anthropometric measures, as well as body composition scanning, which is the percentage body fat and body mass index, BMI. Basically, the health promotion that happens through the spanner in the works occurs via a booklet, which is laid out according to age ranges and health conditions and testing appropriate for that age range. So it really enables discussions to occur based on the participant's age and appropriate health conditions and testing which they should be looking for. The whole analogy comes from car mechanics and links body systems and body functions to car mechanics to try and bridge some of that gap there in terms of that health literacy to make it more applicable and more appropriate to the men. Throughout the health screening and health promotion, we also do need to, at times, conduct referrals when significant issues are identified. And on average, for the events which we run, we really do highlight a number of key issues, but these really do range from around sort of 10 to 15 per event that we specifically refer individuals off to their health professional of choice, which is often their GP, to follow up with specific issues that have been identified that the males participants weren't aware of, and that could cause significant health issues in the near future. This follows on with our duty of care and with consent of participants. And so obviously we highlight issues more than that number. However, these are the significant issues that we really do require those referral pathways. So all health screenings are conducted by students, and these are overseen by registered allied health and nursing professionals. And these are conducted by staff members such as myself and the other co-author, Elise Green, who's a nurse, or other health professionals who volunteer their time. This at the Handy Field Days as well, there's also a number of other health promotion and health check services which are available, such as the farmer health checks. However, the participant numbers, such as we've shown here in 2019, indicate that there is need and demand for such activities at these sorts of events. Thanks, Claire. So we have learned a number of lessons over the years, and after conducting this with multiple iterations, if you are looking at conducting events such as this in the future yourselves, issues such as location and weather play a massive factor in actually getting participants into the tent for the health screening opportunities. In 2019, we were located close to an entry and exit point as well as toilets, which was fantastic in terms of actually getting participants into the tent. And we were really fortunate as well with the iterations that we've had really good weather. And that September timing when the Henty Field Days is it can go one of two ways. And we've been fortunate with good weather to actually attract good participants. I think we would have difficulty in attracting participants if we did have bad weather. So we've been fortunate and fingers crossed with that into the future. The health check duration and choice of tools is also an important thing. It needs to be quick and non-invasive, considering issues such as privacy and infection control. So the measures and the health screening and health promotion that we do is quite quick and low key, but it still does highlight a lot of issues for the men, particularly who aren't seeing their health professionals regularly. There's also a trade-off between room for high volume checks and families. And so we need to juggle this. And in the ideal world, we'd have room for parents and children to wait, etc. And we're working on that into the future. But the opportunity for the students to learn from the men, the Australian Men's Shed Association staff, and from each other is really a key thing that we've learned over the years, and everyone gets that sort of reciprocal benefit. It also allows us to build those training opportunities into the student schedule to learn from the men who are experiencing these significant health issues. And we have learned a lot of lessons along the way with that as well. So we have noted that we're doing more training and prep into preparing the students for future events, as well as things such as debrief following the actual program. What we have learnt too is that things such as the body composition scanner really attracts the younger males and their mates and almost creates a bit of a competition. So that's great for actually bringing in participants for the health screening. And the takeaway Spanner in the Works booklet with the age categories and definitions around health and appropriate screening measures for their age range has been quite important as well. We also too have found that the students are perceived to be somewhat more approachable than your traditional kind of health professionals conducting the screenings, and the participants tend to view them as less threatening and really also enjoy the opportunity to assist with their learning. So they were happy to be involved because they felt like they were contributing and actually giving something back to the students with that. So we really feel that this kind of program is a win-win. It's an immersive experience for the students to develop skills to engage with men about their health, especially when seeing men in high risk indicator groups. So we have explored this promotion activity as an immersive rural training experience for students from city and rural backgrounds. And we are currently have another paper under review as well on this specific elements. So now I'll hand over to Claire to discuss our study and research findings attached to this program.
Thanks, Brent. So I'll be quite quick on this. So how we evaluated the reach of the program. So quite often with these things, health promoters or, getting health checks, as I think Lisa and Natalie have discussed, is there's often the issue of attracting people who are already proactive about their health or are healthier. And it's difficult to engage with those more at risk. And so it becomes a question of, are we engaging, two questions. Did we reach at-risk men through the Spanner in the Works health checks at Henty, and did we reach men with relatively higher risk health indicators than the rural male average? And, we take that approach of comparing to rural men nationally, as opposed to sort of all men nationally, because of the relatively better health outcomes that metro men have compared to rural men. So, it makes sense to compare who we've seen with the sort of target population, so that we get a sort of more of an accurate assessment. And we do that across age groups as well, because of our kind of, we've attracted a lot of, 70% of our men were 45 and over. So, rather than standardizing and going that path, we just compared between age groups to see where we were getting those at-risk men through. So we received ethics as you need to. The research was explained to the men as a distinct aspect of the health check as they came in, so which they could opt in for, and they had to sign a separate consent form for, and they could choose to participate in the research, in the health checks without participating in the research. That was made clear. And they also just had to, asked to participate in a short survey that was just paper-based, based on their age, postcode, and recent GP engagement. And so we had 86% of the 401 men screened agree to participate, and 340 provided a survey response. And so basically, to answer the question, did we reach at-risk rural men? You would have seen, Brent has said that we referred 10 to 15 men with really substantial risk indicators, and that where it's a surprise to them. But what we also see is we were able to reach men with quite high blood pressure. So particularly, so that very high, so over sort of 160, we still saw a substantial proportion of men, and that's 59 men, I think 17% translates to. So quite a high proportion there, quite high risk with waist circumference. And again, that's, as I'll show, partly related to the sort of age distribution of the men that we saw. And then also with that diabetes risk score, more than half, just over half, were high risk. And just quickly on that, when we asked about, who'd seen a GP in the last year, we found the men were really well engaged, actually. So 76% had visited their GP in the last year. But of the 78 men who hadn't seen a GP in the last year, 30 recorded a high diabetes risk score. So again, we've reached people who, have high risk indicators and aren't sort of using GP engagement as an overall sort of indicator of health engagement. 30 men who weren't engaged on this. And then finally, just that comparison between the what we found with our sample, so spanner in the works at Henty sample and the national rural male average. And what you can see up the top there is the higher systolic blood pressure of on average. We removed outliers and things like that, but you can see the difference there, and it's very significant, particularly across the board really. But and then also when we look at waist circumference, we don't see quite that same difference. We see sort of an approaching significance difference in that very young men category of 18 to 24, and that is probably those fitter men who were encouraged to come in because they saw that the body scan that Brent was talking about. So they have a lower waist circumference than the average, but the sort of big differences were at the 45 to 54 group. And I should mention that basically, for the spanner in the works, from 45 plus, men averaged a high risk score, whereas for the national sample, they didn't average above this level at any age. For waist circumference, they averaged above that 101 centimetres from 35 and over, but while for the sort of national rural male average, it was higher, that sort of higher risk level at 45 plus. So again, following the sort of the rural male average at for waist circumference, very closely related to it, but still a bit higher risk there anyway. So good that we're engaging with these men. And just quickly to summarise, there is some limitations with our research. Health practitioners will be particularly aware of it, but we weren't able to follow up with the men screened to know if this led to any changes in their health behaviours. And so we've heard anecdotal reports, but we haven't conducted a study on this. And we don't know anything about the men we didn't reach and why they didn't participate. And I should also note, I think Faisal at the end of the last session noted about culturally and linguistically diverse populations of men, and certainly this was delivered in English for English speakers, and so we don't know what that looks like for the substantial number of people from culturally and linguistically diverse backgrounds that live in rural areas. But overall, our findings kind of suggest that this is quite an effective way to engage men in health checks. And just to follow up from what Lisa and Natalie said as well, often the students learnt from the Men's Shed, Stu and Marty guys as they were promoting it to target the partner, and they're much more receptive, and then through that to engage with the man. And it was also a great way for health students to learn about rural men's health and take maybe a bit more of that literacy into their future work. So if you're interested in making contact with us, if you have any feedback outside of this question time, get in contact with us. Our details are up on our website. And if you have any lessons learned for us, we'd love to hear from you. Thanks.